I had the advantage of being a dementia physician. So I had seen other families go through things well, really well. And I'd seen families do it not so well. So for me, it was helpful that I had seen families who had done this kind of division of labor and everybody had a responsibility and a voice, and that worked out better. And I didn't come up with that on my own. That came from me watching hundreds of other families and which ones kind of rose to the top as the successful families.
Welcome to the All's Authors podcast. We're so glad you found us. We're the global community of authors writing about Alzheimer's and dementia from personal experience to light the way for others. I'm Mary Ann Shuko, a registered nurse, author, and dementia daughter.
And I'm Christy Byrne-Yates, a licensed educational psychologist, dementia daughter, OWL's author, and coach focused on the sandwich generation. Please join us for bi-weekly episodes with our authors as we talk about their dementia journeys, sharing intimate details and painfully obtained knowledge to help others currently on that path.
We hope these stories offer you comfort and support as we strive to break the silence and stigma surrounding a dementia diagnosis.
May one of our authors speak to your experience.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
Hi, this is Roseanne Corcoran, host of Daughterhood the Podcast, and a proud member of All's Authors. I wanted to share some exciting news. All's Authors has a merchandise store. That's right, now you can buy t-shirts, sweatshirts, caps, bags, and more in various colors and All's Authors logos. You can even customize them for an additional charge. All proceeds from the merchandise store benefit All's Authors, so we can continue our mission of not only sharing the web's most comprehensive collection of books and blogs on Alzheimer's disease and dementia, but also support our podcast, Untangling Alzheimer's and Dementia, where each author shares their personal journey to help you learn and cope with an Alzheimer's or dementia diagnosis. You can find the store on allsauthors.com or in the show notes. Thank you, and remember, you are not alone.
Dr. Ann Kenny had been practicing medicine for more than 30 years, recognized by her peers as a top doc in geriatric medicine. But that did not make her caregiving journey with her mother any easier. In fact, when the professional became personal, she sought guidance through the available literature and found little to guide her and her family through the difficult decision-making required in dementia care. So she decided to write her own book, inspired by her experience as a physician and as a daughter, creating the book she wished she'd had for her mother's care. Making Tough Decisions About End-of-Life Care in Dementia was published in 2018 by Johns Hopkins University Press. Dr. Kenny has worked clinically as a geriatrician in nursing homes, assisted living, rehabilitation, and clinical outpatient settings. She's found joy in her work with individuals and their families managing issues related to the diagnosis of dementia. Dr. Kenny's expertise, coupled with her mother's playful spirit and her siblings' openness, support, intelligence, and compassion, allowed for the highest functioning and independence of her mother for several years. In addition to her clinical practice, Dr. Kenny lectures to both healthcare professionals and the public on aging-related issues, including navigating dementia, exercise, nutrition, hormone therapy, death and dying, and frailty. She is an educator of medicine and research skills. She has over 100 scientific publications and presentations focused on improving the care and functioning of older adults. She has also been honored with the Brookdale National Fellow and the prestigious Paul Beeson Physician Faculty Scholar Awards. Hi, Anne. Welcome to the All's Authors podcast. How are you today?
Good. Thank you for having me. It's really a pleasure to be here.
Yes, I'm glad we finally managed to pull this together. We've been scheduling and rescheduling many times, and so many things always pop up, it seems. So it's a pleasure to finally meet you. And I'm doing this solo today because my partner, Christy Byrne-Yates, could not be with us, but she's my co-host. So Christy will be back next time. So I wanted to talk first about your personal dementia caregiving story, which was with your mom, and also your being a physician and how that impacted you. Not only are you a physician, but you actually practice geriatric medicine and issues related to elder care, dementia, and all of that, end of life care. So if we could just talk first, tell me about your mom.
Sure. My mom, her name was Glenabeth, or GB. She was an amazing woman, just full of life and the kind of the life of the party, always laughing. She disciplined with humor, often telling us that she was going to hit us with a board, or a board with a nail in it, or a board with a rusty nail in it, just to get to get us laughing rather than, I mean, she would never hit us with a board, but it was her way of humor. So she was just a real pistol person. And she started noticing some cognitive loss, some word finding trouble, like many people do. And because I was a geriatrician, I probably picked up on it a little bit sooner than others. My sister and I noticed it. My brothers did not. So there was a little tension in the family, as often can happen, that we thought maybe we should be coming in with a little more support. And my mom was really clear that she wanted support, but not too much support. And so we had, 10 years of kind of negotiating. I think I can do it. My sister and I basically gathering information that things might be falling through the cracks a little bit. And she would reluctantly, and we would use that humor back at her, like, we'll hit you with a board with a nail in it. Like, it was kind of what we would do to try to allow us to help put in some of the supports. And what I said to her, as I say to many of my patients, is we want you to have a safety net, and we want that safety net to be low over the tightrope, like in the circus. But as things change, we want that safety net to get a little higher and higher, but we don't want it to touch you until it has to. But we want to know that it's there. And so we kind of went through her 10 years like that, with the idea, and she lived about 1,500 miles away from me. And as she started to progress, my sister went from California to Nebraska to kind of support her as she really started to move into the moderate stages of dementia, really needing more assistance. And then the agreement had been that when my mom kind of moved to the late stages, because I am a palliative care physician as well as a geriatric physician, she likely would move near me. I had small kids at the time, and I couldn't move to her. And so my mom started to not thrive as much with her dementia, but started to decline a bit, but had supports like first an independent assisted living with my sister helping. And then when, little telltale things were happening, she fell down a hill. And eventually she had a mix of Alzheimer's and vascular dementia, and she had a stroke one day, and was hospitalized. And I knew that was kind of our flexion point, that at that point she, this was a major stroke, not a minor stroke. She lost her language at that point. Luckily, we'd had a lot of conversations up until then about things she wanted. And she was very clear she never wanted to live with any of her kids. She said, I raised you guys. I don't want to live with you. But so at that point, my sister was pretty invested in being a caregiver, and so caused a little bit of strife to realize that was the moment that she needed to move to the East Coast where I live. So that strong support of the family had some fraying at the edges, but we did move my mom here, and that started my journey with her as a more day-to-day caregiver, because at that point she was able to move into assisted living still, but a dementia-specific assisted living, because she wasn't making the best choices on safety around walking, needed a little bit more care. So I went to see her every day, because my philosophy was if I'm going to have her be in a locked unit, that she needed an advocate to go and check on her often. And so she and I just developed a whole new relationship then, which was amazing. As she couldn't speak, I had to learn to speak more with my heart. She opened my heart in just amazing ways during those last 2 years. What I did notice in that time, though, was that my approach to care of somebody in the late stages of dementia were not the typical medical approach at the time. This was about 12 years ago now. And I know that because my colleagues were her physicians, and I would say, well, this is happening and I think we should do this. And they go, oh, no, we should do more. And I was like, I started to say we don't need her in the hospital because with any illness, because she's at the late stages of dementia, and the hospital will be more harmful than helpful to her. Mm-hmm. And I said, I think we can handle most things here. And they were like, we probably should go to the hospital for safety's sake. And I was like, her quality of life is more important than safety. And, so there was all this negotiation with the medical system. I wanted to take away some of her medications. And they said things like to me, like, well, she'll have a stroke. I was like, she's had a stroke. She's having strokes on these medications. They could be harming her. So I basically, at that point, started taking her off medications that I thought could be more harmful than helpful, with this balance of, yes, we want her to have her best quality of life. So basically shifted from a curative approach to a palliative approach. But most physicians are definitely on a curative path. And I think by virtue, many people are on a curative path, but she had lived very well with dementia for about 10 years. And this was her trajectory to start to die from dementia. And so I had to talk to my siblings about that, and making these decisions, because they too were getting advice from friends and other people that maybe we weren't doing enough. And I argued that caring for her, that not so much the medical approach, but more the psychosocial approach was what she needed at this point. She needed less medicine and more love. And so we basically I convinced my siblings, you need to come out, because she responds every time she sees one of us. She loved her kids, like amazing. And we were her medicine. So we had strategic visits from people, and it would just boost her up. If she got sick, we would have somebody come visit more than me. My kids were a huge therapy for her. And I couldn't find it. I wanted to help my siblings see this approach and how helpful it was. And my mom had a beautiful last 2 years. I mean, she didn't go to the hospital. She had urinary tract infections, but we treated them with love and ice cream and pain medications. She had a couple of pneumonias, but we didn't treat them with antibiotics. We treated them with, again, love and rest and medications to help with her breathing, but not to treat the pneumonia per se. And when I looked for a book to help my siblings understand this approach, I couldn't find one. So that's when I wrote a book. After my mom died, I was like, this blend of being a geriatrician, a palliative care doctor, and then this emotional roller coaster that we were on with my mom during her 12 years of living and dying from dementia. I realized I had this perspective that was a little unique and might be helpful to other families to make that shift from when do you shift from living well to dying from, and make that much more pleasant and not so much back and forth to the hospital and not so much, am I doing am I doing enough or am I doing too much, but to kind of help guide that, because there is literature out there. It's just not well advertised and hasn't really made it to the medical community.
Mm-hmm. Yeah. So much of what you said resonates with me, both personally and professionally. My nursing experience, I share a little story with you. I was a case manager, and I had this man on my unit. He was 96 years old. He had pneumonia. He had Alzheimer's, and he was being treated. And then we were in the progressive care unit. He was on telemetry. So his wife came into the office one day. She said, "Are you the case manager?" And I said, "Yes." She said, "Please tell me why my husband is still alive." And I don't know what to say. I said, "Well, he's being treated for pneumonia." She says, "No, I have a document here that he signed. My husband is a lawyer, and he doesn't want to be treated with antibiotics if he has pneumonia. He wrote it right here. He just wants to be left alone." Mm-hmm. Okay. So I said, "Well, that's certainly an option." So I gave her a booklet we had in our office. I think it was called Hard Choices for Loving People. Mm-hmm. And I gave that to her. Well, the next thing I know, I'm getting called down the supervisor's office because her husband's physician was outraged that I had interfered in his patient in this manner. So when he saw me, he called me up on it, called me over and started to, reprimand me, although I had done the right thing, and said, "I can't have a patient on my watch die of pneumonia." That was his attitude. He didn't care about anything else. He said, "Pneumonia can be cured." I'm like, but this is his exit.
And right. And what I wanted people to understand is that pneumonia can be cured, mm-hmm. but and urinary tract infections can be cured. But what we're failing to see is that it's upstream. The reason for the pneumonia or the reason for the urinary tract infection is due to the dementia. It is not necessarily due to a bug. So that cannot be cured. The fact that these pneumonias are repeated because for a host of reasons, but one is that we aspirate when we are at the late stages of dementia so that we cannot control our swallowing effectively, and we don't have a vigorous cough reflex. To the body's natural way to defend against pneumonia has been taken away from the brain loss that then has muscle loss or cell loss in the appropriate function. So this is the body's natural way of dying. And as of course we can treat a bug, but and same with the urinary tract. The reason people with dementia get repeated urinary tract infections is not because someone hasn't cleaned them well enough. It's because the bladder doesn't contract vigorously enough to flush out the bugs. And so you can treat those urinary tract infections, but they're going to come back and back and back. And so it is not benign to take antibiotics. I loved my history in being a physician is I did research on frailty as I was a professor at the University of Nebraska, University of Connecticut, and I did frailty research in the morning and took care of people with dementia in the afternoon. And the people with frailty who were cognitively intact taught me so much about how hard it is to take medicines as a much older aging person. And they would tell me these antibiotics make me feel terrible. They wipe me out. They give me a stomach. I don't want to eat. They give me stomach pains. They give me muscle pains. And so then I started thinking, well, the people with dementia have lost the agency to tell me these things. So I quit using antibiotics as much and found that a urinary tract infection, whether they got antibiotics or not, and this is held up by the studies out of Harvard, Susan Mitchell's team, whether you get antibiotics or not in late stage dementia for urinary tract infections doesn't change the course of the urinary tract infection, But the quality of life is worse in the people who got the antibiotics. And it's because of those side effects that those people with frailty taught me. The side effects are worse than the disease. If you treat the pain, people are fine in a couple of days. Their body, the bug clears itself, or our body clears the bug. And if it doesn't, part of that is due to the dementia as well. And we're not doing anyone favors by medicalizing it. So I hear your story. And in fact, I know that one of the things you said was be ready to read a piece of your book. And in the first chapter, I actually bring up a similar story to you about a Dr. Key who was telling a family to put in a feeding tube, and the nurses came to me and they said, the family doesn't want this. They just want to take him home on hospice. And she's just traumatized the wife because she now thinks that she should be doing more. And they said, could you please talk to the doctor and ask her why she's advising the family to put a feeding tube in a gentleman who's been in the hospital every month for the last 6 months. And so when I talked to the doctor, she was like, she just started crying. She goes, I have to offer them something. And I was like, no, yes, you can offer compassion. You can offer solid advice. You can offer a listening ear. You can offer, love, but you don't have to offer a medical intervention. So,
yeah.
We have that doctor that was more, people don't die on my watch, or this woman who is a physician, but still hasn't come to terms with death is part of life. It is just part of life. And there's a time that it happens.
Especially in dementia. I was recently interviewed on another podcast, and we were talking about the medications, the new medications that have come out, and that they have serious side effects, and some of them can be, deadly in some cases. And did I think it was, worth the risk? And I said, it's always worth the risk, I said, because there's no glory in getting to the end of end stage dementia. If you can buy more time on the other side to enjoy your life and it cuts your life short, I would think that would be preferable.
I think it's such a personal, everything is so personal. And, when I was going through this with my mom and when I go through it with a lot of other people, my siblings, I come from a family of 6. And so when I was trying to talk to them about, this is what I think mom wants, or what she's talked to me about, one of the things I did is I said to my siblings, let's all talk about what is worth living for us. If, say, you found out that you had a cognitive loss, and my oldest brother said, as soon as I could not do pretty much anything, I would want to be put on an ice floe and set out to sea. And one of my other brothers said, God gave me breath. I want to take every breath I could get. So, and then the other 4 of us were somewhere in the middle, and it was such an illuminating conversation, because we each it gave us each compassion for each other, because we all had different points on that line where we would say yes or no to life or death. And so my oldest brother most likely would take that medication, because it would give him more time with cognition or death, one or the other. And he was much more black and white like that. My other brother would probably not, because he would think it might shorten my life and I don't want that. And everybody's in between. So I see where people choose these for all of the choices all the time. But the important thing is, what about the person? Like in cognitive loss, we often have to make a choice for someone else because they've lost that voice. And so trying to think, what would the person with the cognitive loss want? Not so much what would I want, what would they want? And really understanding what you would want, and then putting yourself in their shoes and saying, but how are they different from me? Because they may not want what I want.
It's true.
Yeah.
Yeah. And there are a lot of options.
There are.
And there are a lot of things.
The literature right now on slowing the decline is amazing with nutrition and exercise and cognitive stimulation therapy. Mm-hmm. I mean, there's so many options where you don't necessarily have to look to a pill or an infusion to slow the progression. There's so much we can do personally, lifestyle changes. And I don't know if anyone on the podcast has talked about cognitive stimulation therapy, but it is as effective in slowing progression as the acetylcholinesterase inhibitors. And so if you can add that to, a more Mediterranean diet and add that to walking every day and cognitive stimulation therapy, all three of those have zero side effects. So those are choices as well.
Can you just go into a little more detail about cognitive stimulation therapy? Like, what would that entail? How would people access it?
Yeah. Cognitive stimulation therapy is a treatment that's been available in Europe or in England and Ireland for about 20 years. Dr. Spector is the one who came up with it. And it is a group. It's about 6 or 8 week sessions of programming that helps people with confidence. But it actually stimulates parts of your brain that are likely to still have good capacity. And I think when people see how well they're doing, that increases their confidence. And I know that a couple of organizations that I've worked with have it. One is Caring Kind in New York City, has cognitive stimulation therapy, and they do some of it virtually, so you could contact them. I know that there's cognitive stimulation therapy being facilitated out of OY in New York. I know that it's also the St. Louis University is the United States Center for Training People in Cognitive Stimulation Therapy. But I think if you did a search and looked for things in your area or called maybe your area agency on aging or the Alzheimer's Association and asked them if they could look into facilitating a group in your area. But I know that Caring Kind in New York City has a virtual cognitive stimulation therapy programming.
Okay, that's good to know.
Yeah.
I think for many people, especially in early dementia, when they live alone and they refuse to change their residence, that can really lead to adverse outcomes because they're not even getting any stimulation other than like what's on the TV or whatever,
Yeah. Engagement is incredibly important, isn't it? And there's a lot of choices for engagement, even if you live alone. I think depending on where you are in your cognitive loss, finding dementia cafes, it can be a great idea. I mean, so you may be alone, but if you can get out and find safe transportation to outings. A lot of museums have programming for people with cognitive loss. And I know that the American Society for Aging has some virtual museum programming. For people with cognitive loss. So there's choices there. And it's probably worthwhile if you're living alone with cognitive loss to explore some of those things or have a family member. And I often say, have a grandchild because they're so good at searching the internet and they have often they have more time and energy than us Luddites, or for me, I wasn't raised on a computer, but my children can get around it, and they would do stuff to help me help my mom find resources with fun and get them engaged with her.
Yeah, and there are devices out there now specifically for people or that have cognitive impairment or senior citizens or whatever that simplify the process,
Right.
where you're not going to make a mistake and hit the wrong button and lose your place and not be able to get back.
Right.
So people, and they're not that expensive either, some of the ones that I've seen. So that would be another option for people as well.
Yeah. Yeah. That's
Yeah.
good.
So you had mentioned being a long distance caregiver. I was a long distance caregiver, but I only had 250 miles between me and my mom and her husband. So that was pretty doable, easily to drive there in a day,
Yeah.
But you mentioned that it was 1,500 miles. And I know for a lot of caregivers, they are also challenged with this distance
Right.
issue. So how did you manage that?
I made a choice of going, as early on, we just did a lot on the telephone, and my sister-in-law and my brother were my kind of eyes and ears on the ground. I would kind of check in to validate that what my mom was telling me was accurate. Because sometimes she, like I told you, she didn't really want us too much in her business. So we would kind of do a triangulation of, Mom says this, what have you seen? This is what I'm hearing. So good communication with siblings helped, and that we would all kind of check in with each other like that. If I would go out about as she got further in her disease, I went out about every 6 weeks and would just kind of do a check and help kind of try to put in a new system that might help support her more. We went through different variations of pills being simplified, pills in a pill box, pills in a pretty fancy dispenser that would warn us if she didn't take them, and then realizing that she needed actually supervision in taking her pills. So depending on the issue, the trip out every 6 weeks or so would help me figure out what are the big safety issues that we're having. I mean, the trips were mostly for safety issues. And then to help her coordinate, my mom was very social and needed that socialization. And so the trips were also, or the phone calls were often to make sure that she had on her calendar who was taking her where, who was going to be the driver, because she tended to call people often to confirm that she was getting a ride, and that could burn them out. And so my phone calls were often to just kind of be the go-between, like, oh, Mom, we're going over your calendar. I've checked with Mrs. Smith. She's going to be there for you, so that she wouldn't call Mrs. Smith 18 times, things like that. So we just tried to play it by ear. But there was many phone calls, mostly to soothe her, when she, we would put up a big we called it the big calendar. The big calendar had everything. And, but it, as things changed, the big calendar started getting too many cross-offs, and that wasn't working anymore. So, we would look for reasons where we'd need to increase supports. And again, that analogy of the safety net had to get closer and closer. I used to say, closer and closer to your butt, Mom. We got to get that safety net up closer to your butt. So, yeah, it can be challenging, but it definitely worked on my creativity. I had to be creative. And I think every caregiver has to grow their patience and grow their creativity. That's what I found. Not two of my strengths. So there, another thanks to my mom for making sure I became a full adult by the time she left me.
That's funny. You mentioned something about family tension. How many siblings were there?
There's 6 of us.
Okay, so can you describe some of the tensions and how you were able to resolve it, or that you weren't?
Sure. Yeah, sure. We were, there's 6 of us. Only one lived in Nebraska. The other 5 of us lived all over the country. We were raised to be very independent and have our own opinions. So that probably caused a lot of tension because we all had our opinions. My sister and I noticed the changes, probably because we called my mom a lot and noticed the changes before anyone else. And so I think early on, being told by the boys that we were overreacting or over reading caused a little tension because but my sister and I at least had each other so we kind of probably didn't handle that beautifully, and that we just banded together more and probably excluded them a little. And in the lesson learned from that is don't exclude. If they don't believe you or whatever, don't exclude. We should have kept them more in the loop. So that's the lesson learned there. By the time that she started to really need support, my sister actually changed her life and moved from California to Nebraska to be that support because we hadn't done well enough bringing my brothers in, I think. And so my sister took a big hit, that many caregivers do, financially, life balance, all that. At that point, I think it got my brother's attention that my mom was definitely sliding more. And we, and I didn't want because I couldn't be there, I didn't want my sister to burn out at that point. So I think that's when we started bringing my brothers back in and started recognizing what each of our strengths were. And then delegating different responsibilities to each of those strengths. And that was very helpful because then I think we got everybody engaged and involved, and they had their own little area. And I had the advantage of being a dementia physician. So I had seen other families go through things really well. And I'd seen families do it not so well. So for me, it was helpful that I had seen families who had done this kind of division of labor and response. Everybody had a responsibility and a voice, and that worked out better. And I didn't come up with that on my own. That came from me watching hundreds of other families and which ones kind of rose to the top as the successful families in the caregiving journey. I think then the biggest trouble became when my sister was reluctant to have my mom move with me for the last stage. And I think that became a tension with all my siblings because we had all recognized how much of a sacrifice she had made for my mom. And at this time, we didn't want to pull that responsibility from her and I think it just put a lot of strain on all of us because we knew we were hurting her feelings and hurting her emotionally. But the best thing for my mom was for her to come be with me. And so that won out. But it did cause a lot of tension in the family for like kind of Camp Mary or Camp Ann, I more agree with one or the other. And I would say that tension stayed for the whole time the last 2 years of my mom's life, so that we were all dealing with the grief of my mom going to pass and the grief of that we probably were all going to have a new relationship together. And in the end, our relationship is so much better and so much stronger now. But it was almost, we were grieving kind of our family patterns. Like while we each had our strengths and we each had our jobs to take care of my mom, we also each had our own family history, the place, like who was the scapegoat, who was the lonely child, who was, and my mom's illness made us have to kind of break that all apart. And I think there was grief for that as well. And that tension that occurred when my mom came to live near me, I think really broke apart some of those old family patterns because my little brother died in the middle of all this. And so I was the other, which, I'm sure it did not help my mom in her decline. I think that was part of when she really took a step down, when she lost one of her kids, because as I said, her kids were huge life force.
Right. Right. I'm sorry. That's really sad. And what about your dad? Was he already predeceased or?
Yeah, he died when I was in high school. So she had been a widow for many, many, many years. And then she had a second marriage. She got married in her early 70s, and she and her second husband were starting to dement, to get, both of them are starting to show signs of cognitive loss. And his daughters, basically, when he had a hospitalization, and his daughters basically took him away. So she was left, and that's when she moved in. That's when we kind of started to become more of a support and had her move into assisted living, because together they did okay, or they had historically been doing okay for a few years, where his strengths and her strengths luckily were opposite. They couldn't live independently without each other. So when he was gone, she couldn't smell. She had lost her sense of taste and smell, which is not uncommon in people with dementia. But so she would eat rotten food and ended up going to the emergency room for abdominal issues over and over, because she couldn't smell that the food had gone bad, and she would eat it. Yeah. Yeah.
That's sad, though, that they were separated like that.
Yeah. Yeah. That was that was an ugly, I mean, our family stress was nothing compared to that.
Right.
But it was sad.
Well, people trying to do their best for them.
I know. Exactly. And his daughters didn't, just wanted, they had different agendas.
Yeah. Now, my mother's second husband, he had dementia. She did not, but he did. And he had never had children. So he had named me as his person for like medical, legal representation, financial, and all that. Thank God I had that paperwork in place.
Yeah.
For me, I just said, my mother is my priority. So I had to do what I could do. Decisions that were made for him were made for what was best for her.
Yeah.
And I felt bad for him that he didn't have that advocate, a child.
Oh, he did. He did have that advocate. He chose you, and you did.
Yeah, he did choose me. But, sometimes I had to make the harder decisions just because what was best for her. Like for him to go to nursing home, that was what was best for her, because she couldn't take care of him at the house. So.
Right. And I think, that's what my mom's second husband's kids were seeing, that my mom wasn't going to be able to be his caregiver.
Right.
And they were afraid that she would do a bad job. And that's okay. They weren't potentially wrong.
No. And it was better for your family, because then you just could focus on her, and you didn't have to also manage around that, because that could have been full of a lot of potholes and things like that.
Right. And it was for a little bit, there was this really ugly period, but
sure.
I think the outcome, again, turned out to be, we've dealt with what we had to deal with.
Yeah.
Yeah. It sounds like you've been a caregiver for a long and varied amount of people.
Yeah. Well, I was caregiver for the two of them together, and that happened like immediately. It was one of those, one day everything's great, and the next day I'm responsible for them.
Well, the way of the caregiver.
Yeah,
you're not trained for, and you've got it.
Yeah, well, I had some foresight, because he was 9 years younger than her, so she was 80. What was she? 87. He was 79 or something. And I said one day out of the blue, "Do you guys have like a will and power of attorney and papers like that?" And she's like, "Oh yeah, no, we don't need that." And I said, "What are you talking about?" "Yeah, you do." So I said, "We're going." So I made an appointment with the lawyer and took them, and he did all that. And he was just he was a very simple man, to put it lightly, and he wanted to name his nephew to be his person. And we're in the law office, my brother and I, and the two of them. And I said, "Wait a minute, who is your nephew?" And he tells me his name. And I said, "Where is he?" He's like, "I don't know." I said, "I've known you for over 30 years. I have never met your nephew." He's not in your life. You need to pick somebody in your life. So he's like, well, then it's you. It's like,
Oh,
I guess it's me. But, a year later, he was diagnosed with dementia. And if I didn't have that piece of paper, then it would have been so difficult because my mother would have had to been the one. And
that would have been a huge strain on her.
Well, not only that, but she was deaf. She lost her hearing. So you could very hard to communicate with her about anything of any complexity. So that was going to be a problem. She would get nervous. And then she was in an accident, a motor vehicle accident, and she broke many bones all on the right side of her body and was debilitated from that and in a lot of pain. So that was a turning point for them because then he couldn't help her. He was of no use. And he needed to have somebody providing care for him and watching over him. And he was so far gone with his dementia by that point, which we weren't even aware of, that when I called for home care, they refused to send somebody if he was in the house. Yeah, they said they would not subject. He was so abusive to them when they came for the interview. They said, we can't put anybody here, but if he's not here, we can come for your mother. So he went, the doctor, here's their doctor they had for many years. He wasn't helpful at all. So I even went with them to bring up my concerns to the doctor, and he didn't really want to do anything with it. So I said, we need a new doctor. So I found somebody. It was a practice. It was called Complex Geriatric Management. I said, oh, this is perfect. 2 women. I said, oh, this is going to be perfect. And I brought him there, and she didn't come with us because she had been in this accident. She couldn't get around. So it was just him and I, and they told me he needed to go to memory care the first day. I couldn't believe it. I thought he was depressed. We could just give him a pill. And she said, oh, no. We're going to do a workup, she said, but I believe he has dementia to the level that he needs to be in a locked unit. So I was shocked by that. So that's about 2 months later, he was in the unit.
Yeah, so
that's
hard.
denial. And I worked in dementia care, and I knew about it, and I knew about people. But when it's your own family, you don't want to believe it. And I always often say is, what a dementia diagnosis, what it's going to do is bring change. People don't like change. It's going to bring up all these things, and people are going to wonder how it will affect them. How is their personal life going to change? And if you're, going to be involved in the care, I get that all the time. A coworker of mine is caring for her mom now, and it's not even dementia, it's just old age and infirmity. And she's just like, I don't have a minute to myself. The phone's always ringing. I got to do this. You take over somebody else's life.
Yeah.
Making sure they have food, making sure the heat's on, making sure that, the aid shows up, making sure that the checkbook is balanced and the light bill was paid and all that stuff.
Yeah. And that's why you have to have a team. You have to build a team. I mean, that's, again, taking care of so many people over the years. I got to see the people who thrived and those who it hurt a lot. And it's the people who said, I can either, if I have resources, I can pay for some of these things. If I don't have resources, I'm going to build myself a team and then just brainstorm who could be helpful, what are their strengths, and how do you get them to help? Mm-hmm. And know that you'll be the one that helps back in the future. And that people, in the United States, we're such a, independent spirit culture, but people love to help. And
they do.
They love to be helpful. And if you can get past your independent spirit cultural bent and have the courage, again, we're coming back to that courageous. I know before we started recording, we started talking about those courageous conversations. To have the courage to ask for help, your way forward will be so much easier and enjoyable because you'll share it with somebody.
Yeah. There are people who are just waiting to be asked. They have so much to give, they have nowhere to put it. So even to be asked to do a simple task like pick things up at the grocery store or mow the lawn.
Absolutely. Or help me
take the dog for a walk.
Figure out how to put Instacart on my computer. Yeah.
All of those things.
Give me your ideas. Even if you said to somebody, give me 5 ideas, that would, and if only one of them sparked, it'd be better than where you were when you just tried to do it all by yourself.
Yeah.
It's, you know.
Yeah, you can kill yourself trying to do it by yourself.
It is not a one-person job.
No.
It is not.
People do it, but I don't know how well.
Well, we see the statistics. People do it, and it hurts their health.
Mm-hmm.
You had mentioned it. Sometimes when somebody lives alone with dementia, it can be hard on them because they need that engagement. But when you try to caregive alone, it can be hard on you because you need engagement and you need support and you need to take care of your own health and you need balance. And like, I know when my mom was going through her cognitive loss, and as she was getting, like in that time when I was going out to see her every 6 weeks and things were getting more and more complicated, I was having a tough time at work for all kinds of reasons as well. I started seeing a therapist just for support. And that therapist got me to start meditating, which then got me to take better care of myself. And I'm meditating 15 years. Here I am 15 years later with a daily meditation practice that really helps me. And I started journaling. And in that journaling, I could see where I'm trying to do too much by myself. And the journaling helped me see it wouldn't be that bad to ask so-and-so to pick up my kids for me every other week. And I can pay them back in this way if I feel like I need to pay them back. But I need that break. When my mom, and I told you I went to see my mom every day when she lived with me for those 2 years, but there was a point where I had 3 little kids. I had a really intense full-time job, and I was caring for my mom, and I was doing too much. I was making I put myself into a depression like a lot of caregivers do. And I needed that therapist. That therapist said to me, you have to give some of this away. What can you change? And so my kids weren't seeing me at night because I was out seeing my mom. And at first, a lot of the time I took them with me and we did it as a family, but they started to, bristle at that, and they needed some of their own time away from grandma's assisted living. And so I hired somebody at night, and, I would see her then on my way into work in the morning, just a quicker visit. And, I had to find that change and that balance that worked for me so that I didn't fry. I didn't burn out. I did burn out. I burnt out and then learned. And I knew better. I had seen so many people, and in my practice, burn out. And I would say to them, look, you're your family member's hottest commodity. We have to take good care of you because without you, they don't thrive. And still I did it myself.
Yeah. It sounded like you needed your own safety net.
I did. And I built it then. Yeah. And that's, again, the lessons that I have in the book are about your own emotional needs. And, as the care partner, and you're going to go through the good, the bad, and the ugly. There are so many wonderful things about caregiving, and there's so many not so great things. And there's some ugly, ugly things. And again, I would not go back and not have this experience, because I went from this emotionally kind of narrow person to this much broader emotional range because of the caregiving journey that I'm very appreciative for, because it's changed my life in so many ways, but I'm a deeper, richer person for that experience. It's the hero's journey. I've been through the hero's journey. I started and I needed mentors. And then I, went through the hellish part. And luckily I can come out the other end and say, I helped take good care of my mom. She had a good death, and I became a better person for it. And then my giving back is to try to write this book to help other people have that maybe not be as painful on the way, and maybe get the advice from a doctor that they would hope their doctor could give. But I'm not sure a lot of doctors out there have this blend of geriatrics, palliative care, and that personal experience.
Yeah, that's true. Now, you mentioned that you had something to read from the book. Did you want to do that?
I can. The book is full of stories to illustrate points. And I think there's just one story that I would like to read. Yeah. And it's about, again, that shifting focus from cure to comfort. Everybody's names were changed in the story, and sometimes their genders for privacy. So when I read these people's names, it's not their real names. But this is Mary and Ted's story. It's when I first spoke with Mary, a petite woman with warm, deep brown eyes. She never took her hand off Ted. Ted was long, lean, and asleep, but with that droopy, drooling face that accompanies oversedation. Ted's wrists were restrained and an intravenous line snaked into his left arm, an arm wrapped above and below the elbow into a thin, padded board designed to keep his arm from bending and kinking the intravenous tubing. The sheets had been kicked off his legs, and I could see a catheter in place so that Ted did not urinate into the bed. Mary looked embarrassed as I quickly scanned the room and the situation. I'm afraid to move the sheets or speak too loudly for fear of waking him and having him yank it at all the tubes. He just finally settled down. He gets so angry and afraid. He just thrashes around. The thrashing scares me. It's bad enough at home when he gets upset, but here he is connected to all these wires and gizmos. I know he would be appalled at being in bed without being covered. Her eyes well with tears. I just never know whether to bring him here for this. She motions at the intravenous bags, the hospital room, and Ted tied to the bed. Or what would happen if we just stayed home? After Mary spoke a little longer about her and Ted's 45 years of marriage, their children, and their life, I began to bring the conversation back to Ted. His diagnosis, his stage of dementia, the reasons for bringing him into the hospital over the last year, and her initial query, what would happen if we just stayed home? Ted had reached the final stage of dementia. He was sleeping 14 to 16 hours a day, had lost his ability to speak. Mary described only brief periods of, quote, meaningful, quote, interaction, quote. Whenever Ted's behavior changed, he would become more aggressive or become sedate, and Mary knew healthcare providers would find a urinary tract infection or pneumonia. I discussed with Mary the usual course for dementia in the late stages. It's a relief to hear from someone that this is the typical situation. No one has ever talked about what happens as the disease gets worse. I always think I haven't taken good enough care of Ted, and that is why he's declining. We discussed what would happen if they stayed home the next time he was sick. But how can I not treat something that is fixable? It's the question I'm asked most often, and the reason for this book. So for me, that's so many people come to me wondering if I'm doing enough, if I'm not doing enough. And that is why I wrote this book. My siblings, that was the major question of my siblings. I would say it's the major question of a lot of the care partners who come to see me in clinic. How do I know when to stop doing things, or can I stop doing things? I don't think in the United States we're given the option to stop very often. Mm-hmm. And I think it's okay in this disease, and there's guidance. And I think hopefully the book can answer some of those questions.
I think it does. Now, you had mentioned earlier that you were working on some new books. Can you tell us about those?
Yeah, I'm working on a book called Your True North with Teresa Webb. Teresa is a woman, a nurse who lives with frontotemporal dementia and has for several years, I think nearly 20.
Wow.
And she and I collaborated. I know she's she's quite an inspiration. This is a book for people with mild cognitive decline or early cognitive loss, to help them kind of go through their life and see if they can give some answers to what a caregiver might need to know in the future to help take care of them in the later stages, or what their how they might want to die. But it's more than that. It's more, what would you like your legacy to be? Because now is the time to start putting that together. And because we know ways that can make taking care of someone with dementia better, like what if they could start recording some of those things, like what soothes you, what makes you agitated, what makes you more comfortable. And again, it's full of stories, and it's also written with each chapter featuring a person also living with dementia in a book, first person narrative. So probably several of the people that were on your panel, their books have probably been featured in this in this book, so that you get both Teresa's first person narrative and quotes from books of people who are living with dementia. And I think that's important that we then highlight, much like you do here at All's Authors, is to highlight works of people who are living with dementia, so those who are living with dementia can learn from others living through the same thing. And then my second a second book that I'm working on now is with Maureen Matthews, who is the creator of something called To Whom I May Concern, which is a theater performance for people living with cognitive loss to have their voice heard. And if you Google To Whom I May Concern you'll find some of the performances in different places. They're just amazing. But she and I are writing a book about that theater engagement for people who star people living with dementia, and how some of the lessons from those theater performances might be adapted into people's personal lives.
Sounds wonderful. It sounds like you're really busy.
It's been fun. I mean, this is my passion, and if I can help at all in making people living with dementia or their families have an easier time of it. And there's just so much stigma around dementia. There's so much stigma around death. And I find both of them complex and challenging and creative. I think there's so much to learn on this journey of life that dementia has taught me so much, and I hope to pass on that the media shows a lot of the negative, but I think things like All's Authors and some of these other creative people show that there's good to it as well. But to be sure, it's not all sunshine and roses, but life is not all sunshine and roses.
No, I think a lot of the attention is placed upon the end stages, and people don't realize all the life that occurs before that, and it can go on for 10 or 20 years.
Absolutely.
Live well, like the author that you're working with on this book, the 20-year journey.
Exactly.
Writing a book, or participating in the writing of the book. I mean, we have many people in our organization.
I know there's so many All's Authors who are writing with, and they may be writing with somebody who helps them write it, and that's fine. That's what you do to adapt.
Writer,
right?
Journalist,
or a journalist, right? Or someone like me. I mean, I love these. I love this kind of thing, and it's the way I can give back.
Yeah, well, we would love to, have those books in our collection. So let us know when they come out, so that we
will
go through that process and add them to the collection, so people will be able to find them. That'd be wonderful.
That'd be wonderful.
Yeah. Is there anything else you'd like to tell the listeners before we say goodbye?
No, I guess my message would be that, as much as there were ups and downs in my dementia journey with my mother, I would say that it was such a growth experience that don't wallow in the down, because there'll be an up around the corner. Yeah. There can be, but it takes courage. It's a courageous journey. Yeah. And thank you again, Marianne, and all of you guys at All's Authors for all you do to change the dialogue. I'm so inspired by you all.
Thank you so much.
Thank you.
Thank you for listening to Untangling Alzheimer's and Dementia, an All's Authors podcast. For more details on this episode, please see the show notes. If you enjoyed the podcast, please leave a review and subscribe to it on whichever platform you use to listen to your favorite podcasts. For more information on All's Authors, please visit allsauthors.com. While you're there, be sure to browse our online bookstore, where you will find hundreds of carefully vetted books on Alzheimer's and dementia. You can also find us on Twitter, Facebook, Instagram, and LinkedIn. Please email your thoughts on the podcast to allsauthors@gmail.com. We are a 501c3 charitable organization, totally reliant on donations to do what we do. If our authors' stories move you, please consider contributing to our cause. Remember, you are not alone. One can sing a lonely song, but we chose to form a choir and create harmony.
Hi, I'm Anne of All's Authors. When I was caring for my mother with dementia, I searched long and hard for memoirs and personal stories about other caregivers' experiences. I wanted to know not just how other people survived, but how they thrived. Unfortunately, at the time, there was not much available. That's why we created the bookstore at allsauthors.com. Now, busy caregivers can easily browse for just the right resource to guide them on their journey. Books are categorized by relationship and type of dementia, as well as genre. You'll find a helpful title in just minutes using our search tool. So, after the podcast, take a few moments to visit our bookstore at allsauthors.com/bookstore. Remember, you are not alone.